Dear Pure Urology viewers, good evening one and all. Today we are discussing about the suction in RIRS. As you all know, suction has come for mini perk, whatever you say, whirlpool effect, natural gravity, and then suction by the side of the axis sheath, suction through the scope. Now recently, last 1 year, RIRS intrascope suction as well as the axis suction has come. Only few people are doing, and some old traditional surgeons are still opposing. They say that if you do powder, it will anyway pass off. And they say that if fragments are there, you cannot suck it out. So is it correct? But before we thought whether it is correct or not, already papers have published. So let's not neglect this topic. So Dr. Anil Shrestha, who is my close friend from Nepal, a true academician, and lot of interest in endourology, focused on predominantly on the research on RIRS, have multiple papers, will present his experience, whatever that is available to in his nation. He will immediately use it, study it, and come out with his ideas. So that's why let's listen from the other person how, whether it is the truth or whether it will stay or not. So Anil Shrestha has done 2-3 programs with us, but all the youngsters are joining Pure Urology. For them, we will introduce through this presentation. So his topic is whether suction stays or not. It's very interesting to know about Dr. Anil, that he is Associate Professor, Program Coordinator of MCH Urology, Chief of Unit Department of Urology, National Academy of Medical Sciences, Bir Hospital. I have been to there. 2 workshops I have done, live workshops. Fantastic setup they have, including 100 watts homium. Senior Consultant Urologist, B&B Hospital, Nepal. Deputy Chairman, Scientific Committee, Urological Association of Asia. That is a very important post. He has Executive Member, PERLS Aspect. Deputy Treasurer, Nepal Transplantation Society. And Member, Editorial Board, International Journal of Urology. He had organized various live operative workshop, conferences, and symposiums. He was a secretary, also Nepal Association. Performed live surgeries in various national and international conferences. Publications in national and international journals. He has special interest in urolithiasis, flexible uteroscopy, and laser. Very few will write his focus of interest. A lot of people write laser, enucleation, laparoscopy, robotics, everything like that. But he has written clearly flexible ureteroscopy, flexible ureteroscopy, flexible ureteroscopy. Great. So with this, I will hand over the program to my friend. Anil, over to you again. I know you are a crisp speaker. Let's give some thought. What's in your mind? What's the your colleagues across the world are thinking about it? Thank you.
Okay. Thank you, Chandra.
Yeah. Visible.
Okay. Can you see my slides?
Yes, yes. Perfect.
Thank you, Chandra, for kind invitation. It's always pleasure to be in Pure Urology because of the large audience it has gained in last few years, and always pleasure to be with my very dear friend Chandramohan from Hyderabad. Thank you for invitation once again. I bring greetings from Kathmandu, Nepal. So today we'll be speaking on suction in RIRS. Is it going to stay or not?
Yes.
So I don't have anything to disclose. So why suction in RIRS? So before going to discuss this question, let's talk about the treatment modalities for urolithiasis that we have today. Because mainly when we talk about strong treatment, we talk about ESWL, we talk about PCNL and its different varieties of PCNL, like mini PCNL, super mini, micro PCNL, and of course, flexible uteroscopy or RIRS. So what we have to understand is the nature of these surgeries are different. The philosophy is different. See, ESWL was very prevalent in 1980s or early 90s because of its non-invasive nature and fair stone-free rate. Although the morbidities related with ESWL was very low because of relatively low stone-free rate, it is less and less performed and preferred these days, both by surgeons and by patients. So across the globe, the number of ESWL has decreased significantly in last 2 decades. Talking about PCNL, we have to accept that PCNL has got highest stone-free rate among all these 3 modalities. But at the same time, it is very invasive in nature. We have to puncture the kidney, different sizes of ampla sheath. Of course, the puncture-related complications will be there because of the nature of the surgery. We can't ignore that the puncture that we make in PCNL. So it's all about type of surgery we do. Similarly, flexible ureteroscopy, being it's a retrograde approach to the kidney, we have to go through the ureter. We have very limited space. We are using very miniaturized instruments like flexible ureteroscope with deflections and all, with irrigation, laser fiber, different accessories. So the philosophy of all these 3 surgeries are different. That's why the stone-free rate of RIRS is slightly lower than PCNL, which has been proved by various meta-analyses and RCTs. Although the stone-free rate is good, it is not as high as PCNL at this date. So what we think is RIRS should carry higher stone-free rates in order to stay in the scene for the treatment of the renal stone. So to summarize these 3 treatment modalities, if we compare upside and downsides of these 3 treatment modalities, we can clearly see that there are plus and minuses. So we address the lower stone-free rate with flexible ureteroscopy in future. That's why to address this issue, we need suction. So in quest of highest stone-free rate with RIRS and minimal or no morbidity, suction has been introduced for last almost a decade in endourology. So what we expect from suction in RIRS, as we said, stone-free rate with flexible ureteroscopy is fairly good. It's not as high as PCNL. So we want high stone-free rate like in PCNL with flexible ureteroscopy. Another thing is vision, right? Because with the introduction of so-called high-power laser and thulium fiber laser, we predominantly dust the stone, and so-called snow globe effect, the vision goes down, especially when we are treating large stone. And there is a chances that we miss the stone fragments and larger stone fragments behind those ducts. So the vision is very important when we do dusting, and there is lots of dust in pelvic ileal system. One of the very talked and very feared complication of flexible ureteroscopy is fever and infection-related complications. So there are reports as high as 10 to 30% of fever post-uteroscopy, depending upon the surgeons and centers, as well as sepsis has been reported around 4 to 5% in different series. So we can't ignore fever, sepsis, and infection-related complications during flexible ureteroscopy. Since we are retrogradely infusing irrigation fluid during flexible ureteroscopy, the pressure may go high depending upon the irrigation pressure or irrigation flow rate that we use. Lots of people, they use pressurized system or a pressure bag during flexible ureteroscopy, which can be very detrimental, and they can lead to fornicial rupture, sepsis, and bleeding during the procedure. With the introduction of high power laser and thulium fiber laser, temperature has also been an issue during flexible uteroscopy. So there are reports of case reports of renal pseudoaneurysm and series of ureteral strictures and even renal damage following laser lithotripsy, especially when laser lithotripsy is performed with very high total power, wattage, or very high frequency. Then these complications are not uncommon. So temperature is also an issue. And of course, when we compare flexible uteroscopy with PCNL, the operative time is relatively longer. So we also need to address all these issues related to RIRS. So our question is, does introduction of the suction in flexible uteroscopy address all this issue related to RIRS or not? Let's see. There was one very nice review published recently in Actas Urologica Españols. Suction in RIRS can be broadly categorized in sheath suction, scope suction, and catheter suction. So these are broad classifications, and under this we can see there is a simple suction ureteral access sheath, that is non-bendable access sheath, bendable access sheath. There are different types of direct in-suction scope scope suctions. There are steerable catheter suctions. So what all these technology brings during flexible uteroscopy, we will discuss in next few minutes. So let's talk about direct in scope suction first. It's also called this. This is very simple technology. Actually, we don't need very fancy accessories for this. We can do it with regular scope. Actually, it was one of the first users are from India and nearby countries, and one of the first report of this was done by our friend Vineet. So for this, we can use regular scope. We can, any time of the procedure, we can apply it with some modification of three-way valve and some tubings using simple syringe. The benefit is that the ureteral access sheath is not mandatory. So another advantage of this is we can do it in narrow ureter when flexible access when ureteral access sheath is not negotiable, especially in our part of the world. That gives an advantage, and probably it will be a good option for lower pole when we are not able to negotiate so-called fans or navigable access sheath into the lower pole. That may be added advantage of this. But what are the disadvantages of this? Since we use regular scope, there is only one working channel, which is of 3.6 FR, and same channel is used for irrigation and for aspiration of the dust. So the process becomes intermittent. We can't do simultaneous irrigation and suction. That is the main cumbersome part for me when I do this. That causes prolongation of surgery, which has been proved by a study published by our friend Gower in 2022, that when this was compared with even with suction access sheath, non-bendable suction access sheath, the duration of surgery was significantly longer in this group. So we all know that duration of surgery matters in terms of complications and morbidity when we do endourology. So this is one of the very prominent drawback of this, because we have to stop in between, we have to suck it out, then again irrigate for the distension of the pelvic calyceal system. We cannot suck the empty cavity, that's why we have to infuse, then intermittently suck, then infuse, and another drawback of this technology is since we are using 3.6 FR working channel, and most of the times we have laser fiber inside it, we need very fine dust to get it aspirated. And from a lab study conducted by one of the fellow of Professor Traxler has proven that from regular working channel of 3.6 FR, it is only possible to aspirate if the dust is less than 250 micron in size. Although the diameter of 3.6 is almost more than 1 millimeter in size, the 1 millimeter size fragment or dust is not possible to aspirate from regular ureteroscope. So because of this shortcomings of this technology, now companies have modified the scopes. What is going on? Recently in AUA, Pushden have announced that there is a new scope coming, which will be 9.5 FR in outer diameter, but the working channel will be 5.1 FR. That means the outer diameter of scope has remained relatively same or slightly bigger than the usual one that we use, but the irrigation channel or working channel has widened a lot. That is around 140% increase in working channel. That is very relevant for this technique, right? So from this scope, we can do a very comfortable suctioning of the dust, probably, and we need evidence for this. So what we need for this is what I think, if this has to be used for suction in RIRS, I think we need wider working channel. Although lately we have seen that scopes are getting smaller, as small as 6.3 FR by one company. For this, I think we can keep the scope size stable or same around 8-9 FR, and instead we can widen the working channel so that we can do suction from working channel. On the top of that, what we think is there should be simultaneous irrigation or inflow channel as well. Because if there is only one working channel, then we have to stop intermittently like in traditional scope. So there should be additional inflow of the irrigation and separate channel for outflow so that we can do simultaneous irrigation and suction of the dust. So I think this will be the future for this technology, or maybe suction in RIRS as a whole. There is another technology that was introduced from United States, and it was also practiced in India by Nadiad Group. It is called SURE, or Steerable Ureteroscopic Renal Evacuation, or commonly known as CVAC. The first generation CVAC was relatively, it's a blind technique, you know, it's a special tube or sheath that has two channels, outer irrigation lumen and inner suction tube. The suction channel is around 7.5 FR in diameter. So after proper lithotripsy, dusting and fragmentation, the scope is taken out from the access sheath, and this CVAC is introduced to the pelvic calyceal system under fluoroscopic guidance. And there is a steering control dial at the proximal part of the equipment, which can flex and which can deflect the tip of the this CVAC system. So which is done under fluoroscopy. And I think it's a relatively blind procedure to navigate different calyces with this technology. So it's not very safe. There has been reports of good mean stone clearance and good residual stone volume with this CVAC technology, which is also presented in the last AUA in 2024. The good news is that second generation of CVAC has been announced by same Calyxo company. It gives us simultaneous ureteroscopy, lithotripsy, irrigation, aspiration, and even stone collection bottle. So this is the video I got from the website of Calyxo. The passive aspiration during lithotripsy can be done because there is a separate irrigation channel, separate aspiration channel, suction channel, and at the last, when there are fragments, simultaneous micro jet can be injected, and through dedicated suction channel, all the fragments can be sucked out. And this is also equipped with stone collecting bottle. So they claim that this is a one device for 100% stone clearance rate with better vision. So let's jump into another section. It's a suction through the sheath. Suction through the sheath can be divided into non-bendable sheath and bendable sheath, or popularly known as fans these days. Fans has been very popular in our part of the world. I think lots of newcomers, lots of experts in India, even in Nepal and our part of the country are using fans lately with great enthusiasm. And I had an opportunity to attend second urolithiasis meeting of USI last month in Surat, and we had seen great demonstrations of use of fans during flexible ureteroscopy. So very initially, normal access sheath was modified by a Chinese group, and this is the one of the very initial reports by Deng in Journal of Endourology in 2016. They have modified the access sheath with pressure sensor, irrigation sensor, and suction tube that is used for irrigation suction device. So what is fans and what we have fans in modern era? Fans is a flexible and navigable ureteral access sheath with suction device or suction channel. It is specially designed with the flexible teeth that can be deflected with the deflection of the flexible ureteroscope. It has separate suction channel, which is Y channel at the proximal end of the sheath. And generally, the suction sheaths are longer in design than normal access sheath. You can see that we can suck very good size of fragments using fans. So how fans should be introduced or deployed in the kidney? Generally, what we prefer is we prefer around 46 centimeter of fans length, since we have to pass this across the PUJ. We need little longer access sheath, especially for men. We prefer 46 centimeter. For female, we generally use 40 centimeter length of access sheath. Since ureters at our part of the world are not very friendly, we always use smallest available, that is 10-12, although now 9.5 and 11.5 flexible navigable access sheath are also been introduced. The only concern while deploying fans inside the kidney is we should not apply any force. And I prefer putting the access sheath across the PUJ under vision. I don't prefer putting it blindly or even with CM guidance or fluoroscopic guidance. Even the patient is pre-stented, because we know ureter is not a straight tube. It has lots of bends and curves and narrowings. Especially PUJ is very different part of the ureter. PUJ is the most distal part of the urinary tract that we manipulate during flexible ureteroscopy using fans. That's why we have less control. It's not like passing fans at PUJ, because we have to cross additional 20 to 25 centimeter, and our control, our tactile sensation is lost when we reach PUJ. So I prefer passing fans access sheath under vision. Combination of railroading and gentle pushing under vision is what I do. The problem with fans is we still don't know what is the non-negotiability rate through the PUJs, because as we said, when we initially we did flexible uteroscopy, we had lots of discussion about pre-stenting, about our ureters, about necessity of access sheath, size of access sheath. Now I think we will be discussing similar issues again with the introduction of fans, because now we are dealing with PUJ, and PUJ is different. As I said, the PUJ is not straight. When we reach upper ureter to enter the kidney, we have to go slightly down, medial. So the sharp point of the fans access sheath, that is the introducer, is not very soft. I tell you, I don't recommend, and I advise especially novice surgeons to practice extra gentleness, to exercise extra gentleness, or to be more cautious while passing fans access sheath through the PUJ. And we don't know how PUJ is going to behave after passing 10, 12 access sheath across the PUJ, and what will be the stricture rate or what will be the stenosis rate after some time. So that will be another subject for research when we talk about fans. So when we use fans, the suction, the fragments and dust can be sucked out by two techniques. If you want to suck the fragments out, then we have to withdraw the flexible scope all the way to the proximal part of the sheath, so that the fragments comes out from the suction channel. So ergonomically, it's not very easy when we have to introduce it and pull it out multiple times, you know. So one should learn how to do it, and I think there are various techniques by various surgeons. What I prefer is I asked one of the resident to fix the scope, fix the sheath near the genitalia with the left hand, and use right thumb or right finger to control the suction valve. And I rest the shaft of the flexible uteroscope at the fixed position, and I just pull the distal part of the flexible scope in and out. So this keeps the everything very steady, laser fiber, access sheath very steady, and you just have to pull out with left hand, and the job is done very fast and very efficiently. So this is my technique. There are various techniques. Some even passes the scope to the nursing staff or the nurses and do the suction with the left hand. You know, there are individual modification, but this is how I do with fans when I have to retrieve the fragments from the kidney. So for dust suction, one can suck the dust during the lithotripsy. There is one very beautiful video from Chandra demonstrating suctioning of all the dust during the lithotripsy. You know, you can do simultaneous lithotripsy and suctioning of the very fine dust in between the space of flexible scope and the access sheath. So this will also keep the vision very clear and operative time shorter. So there are two techniques of aspirating dust and fragments using fans access sheath. So we had we even did a fans in a 11-year-old female child. She was, of course, pre-stented. The stone was relatively large, 21 centimeter in longest dimension. And the 10-12 access sheath was passed without difficulty after pre-stenting. And at the end of the procedure, we could achieve complete endoscopic and fluoroscopic clearance. And we did we did imaging of this kid with a CT-KUB, and it was complete clearance. So this is one of the I mean, I would say it is a kind of game changer. You know, we don't leave dust anymore to pass it spontaneously after RIS. That, I think this is a very strong point with introduction of suction in flexible uteroscopy. Lots of proponents of PERC or PCNL, they criticize flexible uteroscopy for leaving behind dust and fragments after the procedures, and they claim that this can be nidus for stone recurrence and for re-intervention. So I think suction will answer that issues. So another thing that we should learn about where to place the access sheath for optimum suction effect. You know, there is a very interesting study by from China. It's by Chen et al. Published in 2023 recently. Of course, it is a lab study. It is not possible to do in a human study, the study like this. And they have observed that if we keep the access sheath far from the tip of the scope, then the movement of the water, the jet of the water is also very passive. You can see this light blue color is only faintly visible in left side of the picture, whereas if we put the suction tube and the flexible scope at the adjacent area, then the flow of fluid, irrigation fluid, is more prominent and more I mean efficient. And in the next picture we can see that the suction effect is also more prominent and more effective if we keep the suction I mean the access tip and the scope tip very adjacent, and if it is far, then the suction is inefficient. So for suction to work, it has to enter the kidney through PUJ, and it should be able to negotiate all the calyces, including inferior pole, to suck all the stone out or fragments out of the kidney. Interesting reports. One of the very initial and very encouraging report, I would say, by China again, published in 2024 World Journal of Urology. They compared traditional access sheath with flexible and navigable access sheath regarding stone-free rate. Stone-free rate was significantly higher, and the volume of clearance rate was also significantly higher with flexible and navigable access sheath, and the size and the volume of residual stones, if there are any, were also significantly less in fans group. So these are the initial reports, but when we see the stone-free rate at the 1 month of time, they are similar. You know, there are not much difference in stone-free rate yet. So we need more data, we need more research, and we need more evidence to prove that flexible access sheath really changes the way we do flexible uteroscopy. And I think with time and with more research and evidence, I think this statement will be proven in future. Another study published recently also showed that flexible and navigable access sheath or bendable access sheath are also useful in the treatment of lower pole, when lower pole is considered as one of the not very friendly or unfavorable anatomy when we do flexible uteroscopy or RIRS, because of even after very good lithotripsy in lower pole, there is some difference, or there is lower stone-free rate from the lower pole. That's why these authors, they compared stone-free rate using bendable access sheath, and the stone-free rate using bendable access sheath from the lower pole is as high as non-lower pole group. So it is again very good, you know, but surprisingly the percentage of basket used in lower pole was slightly higher. it is around 50%. So, but again, the re-intervention rate for lower pole was as low as non-lower pole. We have done we have also conducted a lower pole fans study, and it's under review now. We have submitted it in journal, and I hope it will be published soon. And we compared lower pole versus non-lower pole using fans, and we were very delighted that stone-free rate in lower pole is as high as non-lower pole. It can reach around 97-98%. Complication rate is very similar. Only low-grade complication of Clavin-Dindo 1 and 2 have been reported. All the complications were managed only by postoperative double J stent. Infectious complication rate were significantly low. There were no cases of sepsis among 394 RIRS performed during this period. And the re-intervention rate, especially re-RIRS, were nil or negligible. But I just want to remind that all these surgeries across the world, we did it in 25 centers, were done by expert endourologists. So to validate these findings, I think we need more evidence from other centers as well. So with fans, there are we don't have only plus points, advantages. We will be encountering problems as well, or newer sets of complications, or newer sets of post-operative complications using fans. We anticipate that. So as we have discussed earlier, how PUJ is going to behave with fans, we don't know. So injury to the PUJ and pelvic calyceal system can be higher if fans is not used cautiously, or we don't practice gentleness when using fans. There will be this, the picture on the left is my picture. This is the one of the first infundibular tear, which was not very, deep, I would say. It was a very superficial injury that we encountered when doing lower pole fans in one of the patient. There was slight bleeding during procedure, but we could finish the procedure without any difficulty. Nothing was done. There was no extravasation on post-op RPG imaging, but we will be seeing more of mucosal tear or injuries in PCS, especially when we do fancy ureteroscopy in difficult calyces or lower pole. Another issue that we would like to know with fans is how much negative pressure that we should apply to suck the dust or fragment out. It has not been recommended or proposed. The studies that has been published till date have used around 150 to 200 millimeter of mercury of negative pressure so far. But most of the centers and most of the practitioners, they use wall suction, which is available in the OR, and they are not uniform, that the pressure can go very high. So standardization of negative pressure during fans should be done. Since we are using active suction during fans, the rate of irrigation is also becomes important. Initially, it was speculated that if we apply too much of negative pressure inside the pelvic calyceal system, or very abrupt negative pressure inside the pelvic calyceal system, then it will collapse and it will cause the bleeding, like when we decompress the bladder during acute retention of urine, But during my limited experience, I have never encountered bleeding from the calyceal or renal pelvic mucosa due to the suction. This is one video that I recorded. See, you can see very well collapsation of the pelvic calcial system during irrigation, and there is a clear vision without any bleeding. But we have to see it in larger case series, Regarding benefits of fans, it is speculated or it is expected that it will also address the very frequently spoken topic, intrarenal pressure, because intrarenal pressure can cause trauma, fornicial ruptures, bleeding, and infection-related complications like sepsis. So very initial reports in 2016 by Deng et al., they used patent access sheath with the sensor at the tip, pressure sensor and irrigation flow sensor at the tip, and they have set the irrigation flow at 100 milliliter per minute, 100 milliliter per minute. I would say it is very, very high flow rate for flexible uteroscopy. But since they have used the pressure sensor in the flexible, in the access sheath tip, the alarm goes when the pressure reaches around 20 millimeter of mercury. And according to their report, flexible uteroscopy can be done at the pressure of 20 to 30 millimeter of mercury. And if we maintain that pressure inside the kidney during the procedure, then the fever and sepsis rate comes significantly down. And during suction, when we irrigate the system and we aspirate, so there is a continuous flow of the irrigation fluid. That's why the rise in temperature should be minimal. Unfortunately, we don't have much data and much evidence regarding how temperature of the irrigation fluid inside the kidney will behave with the use of suction and fans access sheath. When we use fans, we tend to be a little lazy. When we have some fragments, we think that we can easily aspirate it with the suction access sheath. And at times, those larger fragments, they get stuck at the middle of the access sheath. So it's not very uncommon at those situations that we use laser inside the access sheath, especially if the access sheath is bended like this inside the lower pole. And if you use laser inside the access sheath, and if you hit the access sheath wall and you injure the steel coil that is inside, then the deflection mechanism of the access sheath may be hampered, and it will be difficult for one to retrieve the access sheath. So firing the laser inside the access sheath should be done very cautiously. I would say, if possible, avoid firing laser inside the access sheath, especially when it is in the deflected state. So in such situation, and relatively older concept that was introduced by Professor Traxler will come handy, So how to know that this fragment will come out of 10-12 access sheath? There was one report by Professor Traxler, I think it's around in 2015-16, that if we keep our laser fiber at 1/4 position, and if we touch the stone with that laser fiber, just touch the stone, and if that stone occupies less than 50% of that view in the camera, then it will come out of 10-12 axis sheath. If it occupies more than 50% of the area of that vision, then it's less likely that it will come out of the axis sheath of 10-12 size. So these little tips can be helpful when accessing the fragments that we suck from the fans axis sheath. And of course, we'll be seeing more of accidents and injuries and complications related to fans axis sheath. Since it is very new technology, we are yet to see the complications and accidents. The one very recently posted by our friend Vineet, that the avulsion of distal tip of axis sheath was seen. And I think we'll be seeing more of this if we don't use it cautiously, and if we reuse those scopes then I think we have to be more careful to prevent this kind of situations. Talking about IRP again, renal pelvis or pelvic calyceal system is relatively small cavity. The volume, the capacity of renal pelvis is around 5 to 10 milliliter, depending upon the hydronephrosis and depending upon the extrarenal pelvis, it can go up to 15 milliliter, but generally it is 5 to 10 milliliter. So maintaining the balance between inflow and outflow in cavity of 5 to 10 milliliter is very challenging, but it is very important to very important aspect to maintain the vision, to maintain the IRP temperature. So it is not easy, you know. The newer technology, they are devising some sensor at the tip of the scope so that we can sense the rise in temperature, rise in pressure inside the kidney. But again, it is a matter of few seconds, you know, when pressure can go up or go down. So balancing between irrigation and suction in such a small cavity is very challenging for scientists to design very precise instrument, you know. Pressure sensor, I think it is helpful, but I don't think it is very mandatory, especially in experienced hand. But it is good to have pressure sensor in newer generation scopes. Temperature, we lack evidence, as I said earlier. It will be very interesting to see the change in temperature with normal axis sheath and with fans axis sheath. You know, I'm sure the evidence will come in days to come. So regarding complication of fans, the overall complication with fans is significantly low, as reported by couple of articles, couple of publications in 2022, 23, and I think a number of publications are coming, and the number of publications on fans are rising, and what they all have in common is overall complication is less, febrile and infection rate is less, and urosepsis is significantly less in various series. So this is a good part of suction. So suction can be handy for lower pole. One thing is, since even the distal tip looks very flexible. See, in the left side, the scope has 275 degree of deflection, but with the very brand new flexible axis sheath, the deflection can go only up to 180 degree, you know. Sometimes it is not enough to access the lower pole. So I think we need more steerable, more flexible distal tip in future for the fans, which will allow us to enter lower pole and difficult calyces more easily. So coming to the end, what can be the subject of research? Again, balancing between the suction pressure, irrigation flow is very important. I think this will be one of the hot topic when we talk about suction in RIRS. How PUJ is going to behave. I think research has been designed, and it will come with time that long-term result of PUJ with functional and anatomical changes of PUJ after use of fans will come with time. Use of fans and repeated in and out of the scope through the fans axis sheath, how the scope is going to behave, especially reusable scopes. You know, I personally am not very comfortable using my Flex XC and Flex X2 for this fans axis sheath, because we have to multiple times introduce and come in, go in and come out. And another thing is when we suck the fragment and dust, you know, in between the scope and the axis sheath, we are very skeptical, and we are very we fear that the outer layer of the scope will be damaged by the very sharp end of the stone fragments, you know. So that's why reusable scopes are not very good for fans, I would say. So if you have single use or so-called limited use scope, better use these limited use scope when you using fans for the suction. So do we have ideal suction technique in flexible uteroscopy? I would say we don't have ideal suction technique, because there are different types like this. We have flexible access sheath, we have CVAC technology, we have newer generation Fusion scope of 5.1 working channel, but they all are in investigative phase. We don't have very good and very strong evidence on suction on RIRS. What we need when we talk about suction in RIRS is suction should be done under vision. Like first generation CVAC, it was done under fluoroscopy guidance. I would say it is relatively blind. It is not very safe. So the suction should be done under vision. Pressure should be optimum. Temperature should be low. There should be equal or very good balance between irrigation and suction. While using suction, it should not prolong the operative time very long, like in this technology. So operative time should be lesser than the traditional one, and the technology should be simple. If there is too much of technology, too much gadget, too much information, then surgeon will get confused. So ideal suction technique should have these features. So lastly, suction in RIRS, is it going to stay? I think my answer is it will stay, because it is very essential innovation. Because as we have discussed that the stone-free rate with RIRS is relatively low, we want higher stone-free rate, and we want to mitigate, or we want to lower down the complication rate like temperature, sepsis, pressure with the flexible uteroscopy. So it is very essential innovation. So initial results of like 8 to 10 research have shown very promising results. That's why I think it will stay, and lots of modification coming, lots of modification in fans, in this, and in CVAC. So I think there will be some very good suction technology introduced in coming future, and I believe that it will change the way we treat renal stone. Thank you.
Excellent talk, Anil. That's an excellent, very crisp talk. I must appreciate you prepare well. Whenever we give topic, you prepare well. You take time, but you prepare well.
Thank you, Sandra.
Thank you. So let's go quickly some questions, common questions. There's one important point since long time, last 10 years. My water usage in RIRS is approximately 600 to 700 ml. I have written a paper where the outflow is, if it is less, the results are poor. Today you mentioned that 100 ml per minute is the correct, which I'm feeling happy that 100 ml per minute. I use a 50 ml syringe and flush. So on an average, one RIRS 1 hour duration, I do 1 hour maximum. In that time, it takes 600 to 700 ml. That means 100 ml per minute. So whether you use gravity, whether you use syringe, whether you use pump, you should set in such a way that 100 mm of Hg through the access sheath, how much it can suck in 1 hour should be equal to the same amount which should be infused, because it is continuous. See what I'm saying, the pump was not used all these days. When we were using the pumps initially, complication rates were high. Imagine if you put pump at a rate of 50 ml per minute, which is slow, and you are sucking out at 50 to 60 ml per minute, then you can concentrate only on RIRS. You need not bother about intermittent suction. You continue putly suction. You continuously infuse water. Keep on dusting like what we used to do 5 years back. No fragmentation, no popcorn. Keep on dusting with clear vision. Probably manipulation of the access sheath will be less. And right, you keep in front of it, even if it is lower calyx. Once you keep it in position, then keep on doing. I hope you're understanding. Long explanation I have given. My meaning to say is that you said this switch on, yes or no. It's a one time one. That is a major problem with this. It takes long time.
True.
Whereas in if Iglesia system like TURP, it's very comfortable for the surgeon. So, and second question, have you read about the temperature? Is it in clinical use in Europe? Temperature monitoring, because a lot I am hearing and heard, but nothing is coming to India at least. Monitoring of the temperature. Are we very nearer to those scopes now?
I think there is a temperature sensor in some
I
of
heard
the.
also saying that they will come up in next month.
Yes, but again, see, Chandra, what we have used low power holmium, we have used high power holmium. Now we are using TFL. So we have used three different technologies for stone disintegration, right? So the problem with laser is light. It will, no matter what, it will produce heat, right?
Yeah,
The
of course.
only way to prevent high temperature is to use it judiciously. You have to know your laser, you know how it is going to act.
Yeah.
I mean, if you put on the bulb of 5 watt for 5 minutes, if you put on the bulb of traditional bulb, you
Yeah.
understand, right?
Yeah.
Of 100 watt for 5 minutes, and if you touch it, you will feel the difference. The
Yes, yes,
heat.
of course.
So similar thing, you know. So we don't need very high power and very high frequency laser setting for stone lithotripsy. I mean lithotripsy, because if you use high frequency, then the total power will automatically go high, you know.
Yeah,
So
yeah.
it will hit the water. And very important thing that we should remember is, even if you use like a high power, I mean high frequency laser lithotripsy technique, not all your laser pulses will go into the stone. So you
Yeah, yeah.
will waste it. You
Yeah,
will
yeah.
you will only hit the water. So
Yeah.
if you I think if you use your laser machines properly, and what we call it these days is, for ureter 1010, that means less than 10 watt, less than 10 hertz. For
Yeah.
kidney 2020, that is less than 20 watt, less than 20 hertz. If you
Yeah.
follow this principle, I don't think temperature is very bothersome for endourologists,
Very good
especially
point.
microscopy.
So only thing is the juniors may have objective criteria when they don't understand all this. Technology will tell that you are doing wrong. The
Yes,
scope with thermometer,
of
it will tell,
course.
boss, you are going above 100 degrees centigrade.
Yeah.
Please stop it. Similar way, now people.
I will stop you, Chandra. When I got 120 Moses laser machine in 2017, I
Yeah,
was very, I mean, enthusiastic, you know. And then I did a small lab testing, you know. Actually, I didn't publish it, but with even with holmium, you know, with holmium, if you go very fast, I mean, if you put the frequency very high, like 50 hertz, 0.6, 0.8, 50 hertz, and
yeah.
I have that temperature sensor in the test tube. If you fire continuously for 1 or 2 minutes, then the temperature goes more than 60, 70 degrees Celsius, you know. So it's not only TFL and holmium, you know. Recently, there was a publication, I think it's again from France, and they have encountered renal pseudoaneurysm because of the temperature,
Yeah,
and significant number, I mean, more than half of the number were from holmium group, you know. So both
yeah.
the lasers, if not used properly, are dangerous in terms of temperature.
So incorporation of pressure monitor, incorporation of the temperature monitors at the tip of the scope,
Mhm.
does it increase the cost significantly to the user, is the one thing which is now in the future. If it comes same cost as normal scope, everybody will be aware what's happening inside. Whatever we are talking, it will be evident to the surgeon operating on the screen. That's what I mean to say.
Yes.
Most probably they will be incorporated in the same size scopes in the future.
I think it's coming. I think it's coming already, and some scopes have already launched, and newer scopes will
The
come.
only
But
doubt is whether they will come below 9 French or not. Now, latest, the flexible scope from the Coral Starch is 9.2 again, which will not go in normal access sheath. So again, problem of ureteric damage all will be there. They are bigger.
True.
Standard companies are all making bigger scopes.
True.
The other companies are making small.
Mhm.
I heard 6.5 French is released in Dubai from Pusen as well as Huge Med. We have to see whether it is correct or not.
I think 6.3. It's a 6.3
6.3.
use made, not from Pusen.
Okay.
Pusen, they have not announced it yet, but yes, from HughesMade, they have already launched and it is again already in the market.
Yeah,
And
yeah.
people have already used and posted it. So again, smaller scopes are useful for pediatric group, right?
Yeah.
And tight ureter. Now, if you want to suck, if you are using fans, then it's okay because the ratio between the scope and the sheath will be wider if you use
Yeah.
small scope. Otherwise, I don't think smaller scopes are necessary anymore. 7.5 is fair good.
In one condition, like very small volume stone in children, less than
Children, yeah,
1
children,
centimeter.
it is
It's
useful.
really because you
No
make
doubt.
a powder of 100 pieces and come out. In children, they will pass off. As you know, they drain the small fragments very well. There, you can use it as a ureteric catheter,
True.
visual ureteric catheter. That
So what I think, Chandra, since we are heading towards suction technology in flexible uteroscopy,
yeah,
and both the techniques like sheath suction and scope suction have merits and demerits.
yeah,
But what I think is if the scopes with a very wide working channel will come, I
yeah.
don't think sheath suction will be necessary.
Yes,
And scope suction can be standard suction
yes,
in
yes, yes, yes.
uteroscopy.
Yeah,
I
some,
think,
as you have shown, if two water flows are there and a separate channel is there,
yeah,
oh, it makes a difference.
yes,
Yeah, that is nice. And one more thing I observed, the air bubble, small amount of matrix, small pieces, and small clots. The fans is very useful. The moment you go, if you are seeing all floccules in the kidney and the air bubbles are all disturbing you, fan suction sucks out them very well, and then you can start off nicely again instead of having problem.
true.
Whereas we were doing with the same floccules, and in the midst of those floccules, you continue and finish, and you'll come out. Chances of fever is definitely high in those cases. I mean, you also might have experienced many times there will be some amount of the matrix around the stone. It won't break also very well with the laser. They all form small pieces. They are sucked by fans very well.
Amazing. I also had couple of experience of similar cases, Chandra, and yeah, I was very reluctant whether I should proceed with flexible uteroscopy or not. Since the culture was sterile, the stone was not very big, and the so-called matrix like substance were very minimal. I sucked it out and I finished the procedure without any problem. Another thing is, I think you sure must have encountered there are special kind of stones, when we start lasing, then there is a good I mean layer. Then when you go inside, there is something like clot,
Yeah.
clot thing. So they don't break.
With
It is not
laser.
matrix. It is
Yeah.
covered by hard layer of the stone. When you
Yes.
break, then you have that empty cavity and some clot like
Yes.
structure
Yes.
inside.
Yes.
So
Yes.
these stones are also very useful with fans. You can, the laser doesn't work. Again, something like matrix stone, you can't break. Basketing is not very easy in those cases, and you can really suck it out. I recently had couple of cases of those clot, and we sucked it out very well with fans.
And one more thing, if I will give two choices in the future, one is uh, the 6.5 French scope with 3.6 French channel versus six French scope and 8 French sheath. 6 French scope and 8 French sheath with fans type of sheath. What do you think? Which one is going to a little stay back? 6, 8. versus only 6.2 with a big channel.
6.2 with 3.6 channel.
Channel versus 6 French and 8 French access sheath. 6 French scope, 8 French access sheath. Highly flexible, highly durable.
I would go with the second one.
Second one. That is going to come up.
Yes.
Because
yes.
people can easily reduce 10 to 8 French.
Yes.
In near future, 100% they will be able to.
So I think these fan seat are also getting smaller since 6.3 has been introduced. I think 8.5 fans is coming very soon.
It will come.
Yeah, it's
And
coming.
One more thing, what I observed with fans is, if you don't have more than 45 centimeter length, one person has also asked the question, if you are not able to pass the fans sheath beyond the PUJ, will it work? Will it serve the purpose? I don't think it serves very well, because it sucks the mucosa of the ureter and it collapses. You don't get all the stones into the lumen. What is your opinion?
True. You are very right, Chandra. I had a similar case 2 weeks back. Patient was not pre-stented. I went with fans. I could not introduce. I had shown one video during my presentation. I could not negotiate PUJ with my fans with gentle maneuver. I tried a couple of times. I could not. I did a traditional flexible uteroscopy with only scope inside the kidney. Finished it. Did very good dusting. But at the end, I tried to suck that dust out the upper ureter. It didn't work. It didn't work. And it was well demonstrated by the Chinese group that I showed. The suction tip and the scope tip should be at the adjacent level.
Adjacent level, correct. And as you said, manipulating this fans sheath across the PUJ in a slightly smaller ureters is really technically demanding, and it can lead to disaster. And you cautioned again and again that entire surgery, if you do non-visual, it is too long distance you are operating. Like laparoscopy, you will not have control on cutting or passing the sheath. So you can do mistake. So it's dangerous.
So Chandra, you have a very good demonstration in your Preeti Hospital logo. You have that PUJ there, right? So PUJ is not straight. It's like this. You can see it in your logo. So if you blindly introduce with the introducer, sharp pointed introducer, you can puncture the PUJ, you can puncture the renal pelvis, and you have to terminate the surgery, keep the double J stent and come out. You have to terminate the surgery. Really? So I request all the juniors, especially novice who are using fans, please use under vision whenever possible. Please use under vision.
Correct. And even if it goes inside, one time come back and visually inspect what has happened when you are passing the sheath. Is also, as you come back and then see, if any mild damage has happened, you have to be careful. You should remove it and do normal RIRS and come out.
Yes, so that no doubt.
Further damage is not happen. That will not happen.
No doubt.
Last point I want to ask you, many times in the inferior calyx, you have shown flexible scope bending the access sheath, even though it is highly flexible outside.
Yes.
What I observed is we cannot bend in the inferior calyx. What I am doing is, one person, the surgeon primary will go into deep inferior calyx. He will stay back. He will give the assistant this flexible scope, and slowly you thread 90% of the curvature, it will negotiate. Then quickly make fragments and with whirlpool effect, get them back to pelvis and then only suck. You can't suck every minute particle in the inferior calyx with sheath. You have to create whirlpool effect and get back into the pelvis as much as possible, so that at the end, you don't see anything. But practically keeping the sheath into the inferior calyx, you will fail many times. It's my experience. What is your opinion?
Chandra, I would say the technique that you described, railroading the sheath, I think it works very well with experienced surgeon like you. You have a magical hand. You have that sensation, when to stop, know when to stop. It's not going, now I have to stop and I have to do regular thing, You can do that. I don't think everybody can sense that.
I'm not recommending this across UPJ. Yes. I'm recommending after the flexible scope is inside the kidney, not before.
I understood. Even
Ah,
for
yeah.
lower pole, if you force it and if you damage the
Yeah.
scope, then the deflection mechanism may go and you will
Go,
not
go.
be
Yes.
able to come out.
Go
So,
and spot damage.
what I do is, you have to see, when you pass the scope inside the lower pole, check the infundibulum, whether it is tight or not. Then
Correct.
if it is not going, another thing is you can damage the scope, you can damage the sheath, you can damage the infundibulum.
Infundibulum.
Infundibulum. So it is very risky. If you do gentle passage 1 or 2 times, then it's okay. But
Okay. Okay.
I think novice should stay out of it for lower pole.
Last point, like you have done many papers research on lower pole. If the access sheath is not there and suction is not there, you are using only flexible scope. Uh, Last question. Do
Yes,
you
no
like
problem.
to take these fragments into the upper calyx, or you try to slowly make powder in the in situ? What is your gut feeling? I'm not asking this thing. When really patient wants in a medium volume, a good result, and they are going to target you if you don't give good result, what will be there in your mind to give better clearance?
So what I do is I see whenever I deal with lower pole, I don't regularly measure IPA. I don't think you measure as well. We
Nobody
have
will measure.
fair idea about acute
Yes,
angle. Yeah, we anticipate difficulty according to our experience and imaging.
yes,
One
yes,
thing.
yes.
I always keep my fiber optic scope. Second thing, I always keep my basket ready in lower pole whenever lower pole. Always, even
Correct.
if I don't use, I keep it.
Yes,
And yes, I use combination of both the things, Chandra. If
yeah,
the IPA, if the angle is not very acute, I dust completely. I do popcorning even in the lower pole. Then at the end, after I finish, if I'm happy, then with gentle irrigation, manual irrigation, I replace everything in the pelvis or upper pole. So
okay.
it is no more lower pole stone for me. So if that doesn't work, or if I can't reach all part of the stone in lower pole, then as you said, I fragment it with irrigation. I manipulate the stone fragments. I do basketing, measure stone, then replace, and I do lithotripsy subsequently. So I don't think there is only one solution for lower pole stone. You have to know basketing, you have to know good dusting, you have to know how to judiciously use irrigation to reposition the stone fragments and the dust. So I use combination of everything, Chandra.
Correct. Oliver Traxler used to show in 2007 coagulum putting in the lower calyx when you are doing other calyxes. I think that concept has gone.
Yeah, it is. It was published by Jonathan Cloutier from Canada, one of
Yeah.
his fellow, I think. I tried using once after I read that article, but I didn't like it. So,
Putting
yeah,
blood into the
yes.
into the calyx and waiting for some time. Oh, it's little cumbersome.
No, not only that, Chandra, whenever we do semi-rigid and when sometimes we have to wait for instrument, double J, you pass double J, and if sometimes you have to wait for 5-10 minutes, there are some oozing, right? And after
Spoils.
introducing the flexible uteroscopy, we don't feel comfortable when the
Yes.
clot is covering the stone. So
No, no.
I don't think injecting the blood clot or blood
Yeah.
inside the system is not what I generally prefer.
But the dust gets distributed during RIRS to all calyxes somehow. However good you do, all the calyxes will
True,
have dust. When at the
true.
end of RIRS, you see every calyx have certain amount of 10% dust.
Yes.
They go into all calyxes.
Yeah, but as from your last video of fans, we saw that if you even don't, close the suction valve, if you keep it open and minimal suction, and if you do lithotripsy, then amount of dust inside the kidney
Yeah.
at the end is very minimal, right?
Yes.
So
So that's
fans
the
has that
point.
advantage.
Today we want to share that your last 4 points were very good conclusion. I was thinking, what will you conclude? What will you conclude? Will you use diplomacy or like that? You are very frank that it's a good innovative science needed. You used the word much needed innovative science.
Yes.
I liked that sentence very much. It's needed. It's needed, and early literature is supporting it. So
Yes.
you cannot throw this away. So let's hope in front of our eyes, so many changes have happened, Anil.
Yes,
10,
yes,
15
true.
years back, we all started together. So many changes have happened in RIRS.
True.
It's technology driven. So let's hope we catch them and we do it more enthusiastically, all this
Thank you, Chandra.
for the benefit
Very
of the
well